Thank you very much. You heard Dr. Mihai Georgiou talking about event rates for hospitalized heart failure patients being unacceptable in 2013. And that is very true. Heart failure is the #1 reason for hospitalization and rehospitalization for older Americans. To give you an idea, the older adults when they're hospitalized with heart failure, within a month, over a quarter of them come back to the hospital, and a third of them come back because of heart failure again. So this is a big problem, has been going on for some time. We all knew it, but the situation changed when the new healthcare law mandated CMS to penalize hospitals that had above average hospital readmission rates for their hospitalized older heart failure patients. So we know in Digoxin, a very old and inexpensive drug, that it has a profound impact on hospitalization due to heart failure. What we didn't know for sure that if the effect was could be early enough to have an impact on 30-day admission, if the effect was broad enough to have an impact on all-cause admissions, and if the effect was strong enough in older population where the CMS was focusing on. So we took the DITCH trial data and did exactly that. We said our main outcome is 30-day all-cause hospital readmissions. We couldn't look at hospital readmission because these participants were ambulatory, so any hospitalization was an admission, not readmission. What we found was that Digoxin significantly reduced the risk of all-cause hospital admission within 30 days following randomization. We also found that this benefit extended to 60 days and 90 days, which suggests that the early reduction was not at the expense of later increase in hospitalization. We also saw that numerically patients receiving Digoxin had lower mortality, and this suggests that the reduction in readmission was not at the expense of higher mortality, because if you have higher mortality, it will obviously reduce readmission rates. And finally, you also found that this benefit was pretty homogeneous, including a number of clinically significant subgroups, such as women, heart failure patients who were sicker with the New York Heart Association class 3-4 symptoms, and patients receiving Digoxin in the past or not receiving Digoxin in the past. So now, if we can replicate these findings in more contemporary hospitalized heart failure patients and demonstrate that Digoxin can reduce 30-day all-cause hospital readmission in the post-discharge setting, where patients are obviously sicker because they came out of an acute decompensation, we will have a drug in Digoxin, which is a very low, very old and inexpensive drug that will have an impact on lowering 30-day all-cause readmission, a costly problem for our nation's healthcare system, and of course a very growing older population. Thank you very much.
Thank you. Dr. Bosker?
Okay, just as a way of introduction again, Cam Boskert from Houston. So this is a relook into old data from 1995, the DITCH trial, which was an NHLBI-sponsored large clinical trial. At that time, when the DITCH trial was published, we actually did see the signal for improvement in heart failure admissions. So the knowledge about Digoxin in ambulatory chronic heart failure patients reducing readmission rates for heart failure is not new. But the good news from this study is that we are magnifying and clarifying the divergence of the curves, if you will, seeing the treatment effect very early, within weeks. It's an intriguing observation. The problems or the challenges, I would say, perhaps a call for action, is that we need to be able to find ways to translate that to the current population. The current population, compared to the DITCH data in 1995, are treated with background medications such as beta blockers, device therapies, which were not implemented in the old DIGE trial. So the question, or the challenge, is whether those results could be applicable to the current population. The second important point is the DIGE trial is a chronic heart failure trial. So the emphasis of this publication is perhaps the 30-day CMS mandate of reduction of readmissions post-hospitalization. Therefore, for us to be able to translate the results to acute decompensated heart failure patients would be difficult. Thus, I would caution against stating that in the event that a patient who's not on digoxin, who's currently admitted with acute decompensated heart failure, the first line of therapy is to include digoxin to reduce readmission rates. I don't think that should be the message. The message is from the old chronic ambulatory heart failure patient data, the 30-day readmission rates are robust. Having said that, the trial raises an interesting observation that perhaps we need to study the efficacy of digoxin in acute decompensated heart failure patients, especially for those ones who are not on it. The third point is in the DIGE trial, quite a significant number of patients were already on the medication prior to the enrollment. So that's an issue of pre-existing therapy with continuation of benefit, potentially explaining early divergence of the curves or treatment effect. The study that was conducted in elderly, age over 65. The other thing that we need to be aware is there are certain subpopulations looking at post-hoc analysis of DIGE trial with increased risk for digitoxicity. Digoxin has a narrow safety margin. If the levels are high, especially in low-weight patients, petite females, or elderly, or patients with renal insufficiency, it may come to the toxic levels. And digitoxicity, toxic levels of digoxin, has been associated with increased mortality. But the other side of the coin is when you look at the elderly from the parent trial, they benefit from the treatment of digoxin. So the question then becomes is, perhaps that needs to be dissected out, is in acute heart failure patients with perhaps different digoxin levels, would there be perhaps more safety concerns in elderly population or patients with comorbidities such as renal insufficiency? So those remain unanswered, and I think this re-examination of all data, which pretty much validates what we already knew about digoxin, just poses new homework or new obligations for the trialists to look at de novo implementation of digoxin, perhaps for acute decompensated heart failure, and looking at the safety as well as efficacy margins. Those remain unanswered, and I think we need to be cautious about not advocating suddenly the use of digoxin to reduce 30-day readmission rates to meet the CMS performance metrics. Thank you.
Thank you very much for your very interesting comments as before. I've got a couple of questions. The original DIGE trial talked about measuring levels, like you point.
But if you want, I want to answer because I'm a co-author. And I want to straight things because I keep hearing again and again that DIGE was conducted before beta blocker therapy. If we're going to accept the concept, I know, if we're going to accept this concept, then we should not use an ACE inhibitor, okay? Now, let's keep in mind that DIGE was approved by the FDA based on NIH trial of 70 patients in the late 90s, okay? The data is very robust. The toxicity was not significantly higher in the DIGE group. It's not 1970, it's 1913. And if you use that concept, that incremental value, then let's use only an ICD or a CRT. The problem with digoxin is that there is no company sponsoring digoxin. And what's really bothersome from a patient point of view, that the use of DIGE, a drug approved by the FDA, had decreased from 90% to less than 10%. And if someone is using the word digoxin, It's almost crucified because it's using that word. It's ridiculed. And let's keep in mind that the patient is first. And to dismiss a drug approved by the FDA, a drug that's been used for 2,000 years, so cavalierly, I don't think it's wise. In this climate, when we've been trying for 10 years to find a new drug, and we cannot find a new drug. So dismissing a drug approved by the FDA only 10 years ago, in the face of high event rate, I don't think it's a wise clinical and medical decision.
I don't think anyone's dismissing it. I think what we're trying to focus on is the utility that Dr. Ahmed's brought out about it. And I just said, and in the original DIGE trial, they talked that there was a certain sweet spot for dosing, and a little bit different for men and women. And did you look, my question was, did you look at the DIGE levels in your patients and 30-day readmission rates?
We did not particularly for this analysis, but we did the most comprehensive post-hoc analysis of the DIGE data. We published in 2006 in the European Heart Journal. And talking about DIGE toxicity, we found no evidence that even higher dosage lead to independent increase in mortality. So there is no evidence from the DIGE trial that the digoxin increases risk of mortality independently. Is there an association? Unadjusted, yes, but because the patients who are having higher serum digoxin concentration, receiving higher dose, they were women, elderly, having CKD, so those are the confounders that are increasing mortality. Once we adjust for age and sex and kidney function, there's no independent association. So I personally don't buy that digoxin independently increases mortality in heart failure patients, especially the kind of patients who are in the DIGE trial.
And the other, I have one other question, and that is, were patients with renal insufficiency excluded from the trial? So that did you compare that to patients that were getting DIGE, so it might skew the data?
Well, the DIGE trial excluded patients who had pretty advanced CKD, but if you look at our baseline data in the DIGE trial or in the subset that we analyzed, 60% had CKD by today's definition, GFR less than 60. So this was a population that had pretty what do you call high prevalence of renal insufficiency.
Can I just make a few comments?
Yes.
I think we are all in agreement in the sense that the beneficial role of digoxin, especially in the chronic heart failure population, is well established by the DIGE trial from 1995, which we are redissecting. And in that sense, I don't think the intent is to have a dismissive role, because digoxin is indicated in the guidelines as a class 2 indication for symptomatic heart failure patients. And it's a great add-on or a medication to be considered for improvement in symptoms and or consideration for readmissions. Of course, the DIGE trial did not show survival benefit, but needless to say, our patients are still very symptomatic with high readmission rates. So from that perspective, Dr. Georgiades' emphasis of not having a dismissive, the other side of the coin, press releases that it didn't, demonstrate a major sort of landmark improvement or innovation. The other side of the coin is being too overeager to translate the results to hospitalized heart failure patients as the first line of therapy to initiate. I think the call is we need to try it in those patients, and I think there may be a necessity to maybe consider intravenous or PO IV or PO digoxin to see whether there could be efficacy, which hasn't been done. So the DIGE trial was for chronic heart failure patients, and I think these results allow us to recognize the beneficial role for early reduction in readmission rates and perhaps consider it in a clinical trial, though there is no sponsor, hopefully with some government funding, to examine that role. And I think it being a cheap and available medication will allow us to be able to do that study.
Thank you very much for putting that into perspective. And I think this